I have not heard any reason why you couldn't.
Because we have, you can screw it on and just put your tubes in there.
And I've seen it done. And I haven't heard anyone say you can't or you can. If you don't get the blood with the vacutainer, you might try a syringe that has a, maybe, it's all about the pressure. So that's something I probably need to check, but I've seen that done. And sometimes it doesn't seem very, I don't know what word I want to use, convenient, or it seems almost like it's at a strange angle, but I have seen it done, and I need to check and make sure if there's any reason why that's not supposed to be. Short of, I'll have to get back with you, or I'll find out and tell Tasha what I find out.
I'll let you
Because
know.
if it works, and there's no reason not to, sure. And I would just think sometimes maybe if the suction isn't at the right leverage of pull, that you may not get your blood. Okay, and then, they do become clotted. And it can be it can be literally that the patient just develops the sheath or the fibrin so fast. Okay, so it says if you find an occlusion, you want to check and make sure that there's not a kink. And occasionally it can get kinked right under the skin, and just even dressing change and maybe a repositioning of the end of the catheter can do. I went to one place and tried to flush and couldn't, took the cap off and flushed, it was fine, and I was called an hour away. And basically the cap was functioning. It wouldn't let anything go through it for some reason, I'm not even sure why, but just changed the cap on it and it flushed. And then checked the clamps, which usually if we try to flush and it doesn't, then we will do that, I'm always running around like a bulldozer, so. But, just so check a few things and make sure. Do your pause push and see if that doesn't maybe open it up a little bit. Don't push really, really hard, but you can give a little bit of pressure. If you go and meet a little bit of resistance, that's really not too uncommon. Just add a little bit. Sometimes if you draw back and then flush, there'll just be something at the end, a thin layer that will, open up. Most of it will dissolve. I don't think that it sends any great embolism in, because we use these all the time, and they always develop different things. Just this coating around it. But if you have very much trouble at all, if you put cath flow in, you draw it up in 2 cc's of sterile water, put it into the catheter. It's half time, I think is an hour, but for a really occluded pick, just put it in and leave it for a couple hours. Come back, draw it out, flush the pick. It almost always cleans it right out, unless there is maybe a malfunction or a kink somewhere in there. And if you do, then the pick needs to be replaced. Sometimes they'll tell you to do it twice though before they check, but if I leave it in for an hour, I've never had it not open up the pit, if that was the problem of it. So yeah, you just need an order for the Activase, and then it comes together. Activase is kept, this is what Anaplace, but it's all the same. We used to give it years ago. We did trials for people that came in with heart attacks, and we would do a slow drip of TPA and dissolve the clot. It was, and for whatever reason, I think because they went to the cath labs, that they kind of got away from it, and I'm sure they had some problems, because it does reduce clotting time substantially. But this is a very low dose, and 2.2 sterile water into your 10 cc syringe. It dissolves very easily, and you put it in the occluded line. It's best if you have a double to put it in each line. They end at the same place, so if you open one line and the other one's partially occluded, they're cut off flat together. So to put it in both lines is the optimal thing to do. And then you can, 30 minutes is the minimum. Put it in for 30 minutes, and then you can just check. If you have a blood return, you can go on with it. If you don't, you can leave it back in and wait longer. once again, if you're not busy and if you don't need it and you're doing something else, put it in for an hour and let it stay. It's not gonna cause any problems. It is a blood dissolver though, a clot dissolver, as opposed to heparin that is a blood thinner. So again, you would monitor for any signs of bleeding. I have not seen on this low dose any problems. Once again, we used to monitor them very closely years ago when we were running quite a high dose in. So then, it says up to additional 90 minutes. So that's up to your 2 hours. But if you have the hour to 2 hours just to put it in, I've heard different stories. There are IV teams that would go around and do all of them in the hospital and just put the cath flow in and go back a while later. But the strength of the medicine is pretty much gone in 2 hours, according to the cath flow representative. So when you get ready to remove a PICC line, basically you probably just take them out when they get home. You're not going to probably take their PICC line out anymore. We don't leave anyone sitting in the hospital without a IV line in case something happens. So, but we suggest to most people that when you're done with a PICC, that it doesn't just stay in case, because it's a risk of infection. We would like it kind of to be there when we want it, but a lot of times, doctors want them out. They certainly, unless they're going to get IV antibiotics at home, aren't going to go home with them. So you just get your order to remove them. You don't really have to mask to take them out, but you do want to cover the end with an occlusive dressing. The one risk that is most talked about is a possible air embolism. Now this is more common in your chest or your neck because of the short distance that a bubble of air can get into the vessel and then cause the same symptoms as someone that has like a PE or something. They're going to get anxious and lightheaded and sometimes complain of chest pain. And PICC's very low risk just because of the distance. But we do put an occlusive dressing over it. I've heard to use a little bit of antibiotic ointment right over just to seal it off at the site, and ask the person to leave it on for 24 hours, and then it'll be done. You just have the patient get comfortable. They don't really have to be laying down. You use regular gloves. You ask them to bear down. Do the Valsalva maneuver, and then just pull the PICC out. If you meet a little resistance, just go on ahead and give a tug. Now if you really, you shouldn't stand there and have to do that, but sometimes it'll kind of heal around it a little bit, especially in this area. It may have, developed kind of a little scar tissue that grabs or something, but it should most of them come out very smoothly, very, very smoothly. And then that's when you want to look at the end of it, see how long it is, and then find your document and make sure that it's 40 centimeters long. Okay, it's just a protective confirmation of the PICC line. Put a little pressure. They don't usually bleed because it's healed from here to here, but they can, depending on the patient's bleeding times and different things. And then I frequently use a IV dressing kit to go in and pull a PICC line, because it has your tegaderm, it has your gauze in it, and you just need a little thing of acetration. Okay, Karen's is my boss, so that's why her name's up there. So, is there anything that we didn't cover about doing this? Any problems that you've had with PICC lines that maybe were confusing at the time, or?
I have the aspiration back, that's the only thing.
Yeah. Well, I would try, like I said, try that, especially with as often as you guys use them. Try that push pause and see if it doesn't kind of whip that tip a little bit.
If I'm not mistaken, don't we just flush every 12 hours?
Mm-hmm.
We don't flush every 8. I think we just,
Our policies are for.
yeah.
And we're gonna be reviewing the policy.
And
I've been
that- and
comparing
there's
it with
heparin
other,
too.
St. Vincent facilities.
Okay.
Because we use heparin
Mhm.
after every time we.
Right.
Do you?
Right.
After every time we do something with those PICC lines, we flush with saline and heparin.
Okay.
Which would be probably fine with 12 hours. I personally don't think there's anything wrong with that. To go and just say, we never use heparin, we only use saline, when we could save a lot of PICC lines when heparin was used wisely. So, but most of the time, if you have a continuous line going of fluid, it's not gonna need flushing. Most of your lines are probably being used at least every 8 hours while they're here.
Well,
You know.
sometimes they're getting more than one infusion, so they may get flushed with heparin every couple of hours.
Yeah, well, see, and I don't know that that's necessary,
Yeah.
but
It's
Just
that's.
like if you have,
That's
if you
the
pull
concern.
You
with
have a
blood,
couple different antibiotics,
I think
and
so.
you pull with blood.
blood and,
Yeah, it should, I mean, if you're using a line that frequently, you shouldn't need heparin,
Right.
you know.
I think our policy still states use heparin, right?
Haven't found an updated policy, so
I
Yeah.
think-
it's
I think
very
it's the-
old.
I think
Very
um,
vague.
But
It is vague.
what
Because I
we're
think-
going to be going to is more specific.
Okay.
Um,
You know, what Tasha mentioned when I first came here, and I think, is that it should be available for our discretion. And if you know that someone's using a line, you maybe their PICC line every 24 hours for bank, you're gonna, I mean, to put heparin in, your 12-hour flushes, that's great. Now, once again, these valve picks say they can go longer. In fact, somebody might have a valve pick that's getting chemo and they'll say it can get flushed once a week. That kind of makes me nervous, but that's just because I don't want them to lose their pick. But a non-valve with the clamp ideally can't be flushed too much. So we suggest every 8 hours, just to, keep the risk of it developing that sheath too much.
And that's just with saline, right, now?
Yeah, that's what she's saying. So, if you're using heparin, I would use heparin maybe once or twice a day to keep them on. I don't think it would be necessary to use heparin if you're using the line 5 times a day. Even 50 units of heparin isn't that bad, but it probably isn't necessary. So if you have the option to use heparin, when you have a line that you notice, isn't being used that much, or that person just seems to, clot real easily, you tried it once and it seemed to be clogging a bit, so you flushed it and it opened up, but then you used heparin just because it would be an added substance to keep it open, but, and that's, once again, that's kind of what you guys think's best. I like having the ability to use my nursing skills, my sense of, well, this would be good for this, and it doesn't sound like they've taken it away. I think I don't know if I told you here or just was telling her, I go to facilities where they've taken heparin away and they won't let them have it. If I had a port and they wouldn't let them heparinize it, I would be upset. That's a surgical procedure, and if it gets clogged up, it has to be taken out and replaced, and then it leaves scar tissue, it sometimes,
Very expensive.
well, that too. What a way, if we can keep them open, I feel the same way with a PICC line. I put so many lines in little old ladies, they just have my heart. These 90-year-old ladies, I only want them to have one. I don't want them to have to get stuck again. I want them to use it for blood draws, I want them to, use this line as long as it's in, so this woman doesn't have to get stuck. But, so, a lot of the nursing homes, they have heparin and they can do that, and I tell them the same thing, use it. Because I know they're not gonna get flushing it. Oh, no. In fact, yesterday I was at a place where I changed a dressing that I had put the PICC line in 3 weeks ago. I'm gonna tell them, oh, you guys are, they're so busy. Can I change that? Because it's just good care for it, and thank God it looked fine. But the same way with heparin.